So, I think reflecting on those good encounters, those bad encounters, being human, be as human as you can be, like what values do you have that you want to show to the patient that can be part of that. I've always someone who likes to be like warm and humorous and easygoing. I have a little stash of emergency chocolate in clinic, for example, because we'll have people come in, you can tell they're rushed, they're flustered, and they're saying, I can't even have time for lunch. Do you know what you need? Emergency chocolate. Open up the emergency chocolate drawer.
Nice.
That gets people on side really quickly. Just little things like that. That's just like, let's kind of meet on that kind of level, and bring the values in that you think are important.
That's great. That's quality. That's great. Like, these are the things, like, that's it. That's the only thing I need to take from this podcast is chocolate, emergency chocolate. Thank you for listening to another episode of Teacup. Before we get into the episode, I just wanted to let people know what's going on with my course, Unraveling S&C for Therapists. I work with companies called HDPN, Encore, and Training Made Easy, which all have available dates on their sites. Or you can go to my bio on Instagram, which is at ProCare Sports, for all available course dates. If anyone is interested in hosting a course, please email me on info@procaresportsmedicine.com. Again, you can DM me on Instagram if you prefer. The course itself is designed for any level of therapist looking to improve their coaching skills, alongside building patient commitment into their rehab programs, intertwining S&C principles as we go along. Finally, I'm also the co-founder of the Unbound project, and this is a really new, exciting project looking to build a community for healthcare professionals to connect, collaborate, and share ideas. This includes webinars and in-person face-to-face events, and more information is available at Unbound Project on Instagram or LinkedIn, or if you email us on hello@unbound-project.com for more details.
Well done. You have finally discovered the most important health podcast you will ever need as a medical professional. The conversations you are about to hear are guaranteed to change your clinical practice and hopefully transform you into a better conversationalist. They could even make you better crack at parties. Welcome to Teacup, where swearing is guaranteed.
Tom Goom, the OG of running injuries. Welcome.
Thank you. Good evening.
You did. There's a slight delay on that one. I just called you the OG of running injuries, Tom. You should be flattered by that.
I am. I don't think I've ever been called that before, Andrew. Thank you very much.
It's all right. It's all right. I know. It's definitely something that when I don't know. It's taken me too long to get you on here. It's definitely one of the people I've known the most from social media, and always without smoke up your arse, which I don't like to do to people because it's embarrassing. But definitely from infographic and a style of communication from your information, I rob your shit all the time, which is brilliant. As in just the way you just simple things that I'm always like, that's really useful. You've got one infographic that I have a little Tom Goon literally folder, I think, on my phone of that's going to be really useful to have. And it's the one of the foot where you've got all the different palpation points of that one. I love that. Oh
yeah, the stress fractures of the foot and ankle one. Yeah, I was quite pleased with that one.
Yeah, there's a couple. So anyone who, like, if they haven't heard of you, that'd be a bit mental. But if they don't, your infographics are quality for that. And they're just ones of those you just straight, and even patients like them, because even when you show them, they say, look, it's just, yeah, really good. I definitely have to say that about you from that point of view. Of you're my go-to for a lot of that kind of stuff. So thank you for that over the years, stealing all your stuff.
Yeah. Thank you. And I see you've had some brilliant people on the show recently, haven't you? You've had Joe Gibson and Michelle Lyons. I was listening to that one on the menopause stuff. That was really good. Mehmet Cem, you've had an all-star cast on here, haven't you?
Yeah, no, they've been, and you know what, all of those people I have that's the other thing as well. They're always sound, you know what I mean? Like from the point of view of reaching out and saying for yourself, you've always been. Anyone I get on here has always been really helpful, and that's kind of one of the things I always like to promote. People who've just been generally sound, you know what I mean? Because there is, let's put it straight. There is a lot of dickheads out there in our world. And,
there are. Yeah,
do you know what
definitely.
I mean?
Social media is full of them, unfortunately, isn't it?
Yeah.
Best
So,
avoided.
Yeah, sure. The one thing I did hear an interview with you a long time ago. Was it? And I just thought to start with this though. Did you Did you want to be a stand-up comedian, or did I hear that right?
Yeah, I had a stab at it, but I wasn't very good. I did do some gigs, and I had one where I absolutely died on my arse, and it was really embarrassing. But I had one or two good ones. I played to quite a big gig, about 120 people in Hove, and that went quite well. So I was quite chuffed with that. I should have kind of retired then at my peak. But yeah, it was a good thing to do. It gives you a lot of confidence doing other stuff. If you've been in a room trying to make people laugh and you failed at that and you know how awkward that is, anything else seems quite easy after that, to be honest.
Yeah, I read what's his name's book, Ramesh Ranganathan. When he was starting off as well, and they all the comedians do talk about that like horrendous death, and it happens to everyone. But I guess it's like, you've been doing courses for a long time, and I've been doing it for about 10 years, and people kind of go, when you haven't done it before, they're just like, Christ, how are you doing that? And it actually, like, you know what I mean? It's the same thing, isn't it? Like, you cringe at what you probably said 10 years ago,
Absolutely. And I think a lot of people find public speaking challenging, and I think the more you do it, the easier it gets. But I think there's still moments for all of us that are doing it. Like yourself, you've been doing it for 10 years. I'm sure there's still moments where it can be a bit nerve-wracking. Things do go wrong, and you have to adjust. And sometimes when things go wrong, actually, it's a good opportunity to sort of show your human side a little bit. And that's where I tend to lean towards. I did a course over in Ipswich that was not far away from a farm, and I kept getting heckled by a chicken. Like, it kept on squawking really loudly, and you just have to go with it and just have a bit of fun with it after a while, because it's better than getting stressed and getting wound up when things go wrong, I think.
Yeah, I think so. I think it's like, I suppose, comparing it. I'm not comparing to professional athletes, but athletes, that kind of pre-talk is the worst bit. You just want to crack on, don't you? You want to just get used to people, and you're half an hour in and you get the lie of the room, and you start to, it's much easier, isn't it? Even day 2 as well. Once you get, if you do a 2-day, it's more relaxed, isn't it? You wake up the next morning going, what the lay of the land is, which is interesting. Right, let's go into quick fire questions. So you just have to pick one or the other, Tom.
Okay.
Steve Coogan or Frankie Boyle?
Steve Coogan.
Nice. Therapist or coach?
Coach.
Perfect form or happy runner?
Happy runner.
Irish or Scots whiskey?
Oh, Scots. Just about.
So that's the end of the podcast. Load management or movement quality?
Load management.
Treat the tissue or train the system?
Ooh, train the system, I think.
Cool. Watch pace or run by feel?
I'm going to say watch pace on that one.
Cool. Fish or chips?
Ooh, chips.
Education or hands-on treatment?
Education.
Yeah, I'm not, and that was a bit of a shit one. I kind of decided not to. I was going to put that one in, but anyway, yeah, I get it. Rehab drills or real running exposure?
Real running exposure every time.
Nice. Fix pain or build confidence?
Build confidence.
Running with music or running in silence?
Ooh, running in silence. Actually, I prefer these days.
Oh, yeah. These days there was a change in that.
Used to run with music and podcasts and stuff back in the day, and audiobooks, but I don't know, now I just prefer not to have the noise, really.
What about music, though?
What about music? No, I mean, used to run with music, but no, not so much anymore. I just like that, just being out there and having the freedom and no distractions, really.
Yeah, cool. And then moving on to music, actually, which was the other question I like to ask people, is like, I think I've sent you this anyway, but what kind of music, what would your personality tell you? You're teaching, you as a physio, you as a person, what would you like to pick with regards to music?
I would probably go with a bit of grunge, something like Pearl Jam, mainly because I peaked in the 90s and I've kind of gone downhill since then. But also, I like the kind of emotional side of life, and I kind of like that kind of music. That's sort of how I am a bit, I reckon.
Okay, interesting emotions. And I guess suppose that kind of lays in. So like the questions with you, like sometimes I've kind of gone a bit. I definitely wanted to get into a bit more nitty gritty around running, so I definitely framed these. So we'll start with the first one I sent over, which was. And when I wrote it out, you built your career. Sounds like you built your career around runners and their injuries. What drew you into running in the first place? And how has your own running identity shaped the way you communicate with your patients and fellow clinicians?
So I was a runner at school, even primary school. Used to compete in the cross countries. Competed for my secondary school as well. So I've always been a runner at various different levels, and that's obviously continued while I was a physio. And I think one of the biggest things that sort of shaped me was doing my first longer distances like marathons, and really encountering a lot of the issues that a lot of runners get with injuries, with fatigue and things like that. And looking at that from that kind of physio point of view really interested me. And at the time I was actually mainly working in persistent pain. And I saw there was actually quite a lot of overlap between some of the persistent pain stuff I was doing around like pacing activity, graded return, that kind of thing, and working with runners. But it had a lot of the other stuff I love too, like strength and conditioning, like movement analysis. So it just seemed to have everything that I liked as a physio, and I also had that passion as a runner as well. So I think it gelled quite well, that kind of experience and that choice of specialization.
So with your communication approach though, so you just touched on it there, persistent pain, and there's a lot of crossovers, isn't there? I think we're all dealing with humans, whether it's persistent pain or whether they want to run a 2-hour marathon. So I guess the idea is, what did you take from the persistent pain side of things that you think is like a superpower when it comes to like your typical runner who might come in and just say Achilles tendinopathy, I want to run 10Ks 3-4 times a week. Like what was the crossover? What kind of things did you learn?
So a big one, I think, is really trying to be like mindful of our language that we use and how that actually affects the person's perception of their activity. And actually empathy, I think, is a key thing. We know in persistent pain, a lot of people get dismissed. They get sort of pushed away sometimes. Their experience gets squashed. Whereas I think it's more about validating and empathizing and understanding. And the same's true in runners, particularly empathizing and understanding why running's important. Because the worst thing you can say to a runner is, well, if it hurts to run, don't run. Because that's showing a complete lack of empathy and understanding. So I think there's a lot of that communication around, recognizing I can see that this, running is really important to you. I can see why, and maybe like reflect back what they've said to you. And then that kind of helps to connect with them, and then you can work going forward. So I think that empathy, that choice of language, and of course, being a runner that's doing marathons and things whilst treating these patients, you can genuinely empathize because you know what that experience is like. And I think that does help getting people on side. But also a big part of persistent pain is some of the things that perhaps aren't helpful that get said to people. They're kind of classic stories of people who've been told horrible things like they've got a crumbling spine, or you get stuff like that in runners who are told, well, you're not built for running, or you should stop altogether because it's damaging. So there's quite a lot of overlap there where we're trying to unpick those negative messages and actually come back with something a bit more positive, a bit more empathy, a little bit more focused on what they want.
Yeah, I'll dive into the empathy bit. It's definitely a topic I talk about on my course a lot when it comes to, is it, just even highlighting it as a discussion of how you work on it as a skill. What do you use from your own life? A classic one is if you experienced it, like you said, you're a runner, so you kind of know what that would be like. Like how, I think everyone has a different approach, and certainly on a podcast, you're not going to get this, it's difficult. That's why communication is difficult. But like when it comes to empathy, is it something that does it fluctuate with the patients you have and depending on your connection with them? Like what do you think about that kind of idea? Like sometimes I don't know, sometimes I lean in a bit heavy on some people in a good way, your connection and that. What's your thoughts on that side of things, and where you push it and the boundaries around that?
Yeah, I do think it's one of those skills that takes quite a lot of judgment. There are times where you sense that someone perhaps needs a bit of empathy and validation for their choices. Perhaps they've struggled to make a decision on something and they need someone to actually be able to validate their choice. And other times where you may feel that perhaps they're a bit resistant even to that. They're not maybe looking to you for that. So there's a judgment call that goes on it. But we had an example in clinic the other day where we had a young athlete attend with their parent, and the parent was talking to this young athlete, being really encouraging things, but they'd recognised that this young athlete was anxious about returning to their sport. And the parent had picked up on that and they were talking about that. And I saw it as an opportunity to say, well, actually, I can see why you would be anxious, because this means a huge amount to you. You know, this has been a huge part of your life. You're competing at a high level. Your friends are involved in the sport. So I can totally understand why you might be a bit anxious to go back and have a setback. That makes a lot of sense. But you know, we'll be here to support you through that, and then opening up the opportunity for them by saying, you know, is there something that you're concerned about? Is there a particular thing you'd like to chat through? So that would be the angle I might tend to go with, say, in that situation, allowing them to have a bit of that anxiety, making it normal for them, and then giving them the opportunity to discuss things they're concerned about.
Yeah, again, it's normalizing the emotion they're feeling, isn't it? And sitting with that, which is, I think it's a great, you know, again, so difficult to kind of try and teach that to another therapist in a way. Do you know what I mean? You kind of have to experience that as a human and just lean into some of those kind of emotions. And that's the thing, isn't it? I'm not sure we certainly don't get trained in that, do we? You know, that emotional intelligence in the moment. Do you know what I mean? Like how someone is that. It took me a long time to just be like, you know what, fucking, I'm gonna ask about that. You know, that is they're in pain here about, you know, or just try and put yourself in those shoes, even if they are a 16-year-old. International or whatever it might be, something far from where you are. I think what do you? So when you're teaching, or when you're obviously supervising physios, do you teach that? What do you have any discussions around this kind of stuff and conversations?
Yeah, absolutely. I mean, coming back to what you were saying there, sometimes if we're not sure, I think it's fair to ask the patient. I sometimes say, I'm not really sure if they'll want to broach that. So they've brought something up, and I might say, well, could we talk about that? Are you open to discussing that a little bit? And 9 times out of 10, they'll say, yeah, absolutely. And then you've got that opportunity to go into it. Occasionally, they'll say, do you know what, I'd rather not touch on that. I'd rather focus on this. No problem. But you're kind of, if you're not sure, you put the ownership back on them. I think for me, it's also recognizing some of the things that can actually kind of erode the rapport, can make it more difficult for you to establish a relationship with your patient. I used to work with a physio many years ago now. It was an absolutely fantastic physio, but one of the things that we fed back to them is that they would come into the session, the patient would sit down, and they'd have the patient's notes on their lap, and they'd spend 3 or 4 minutes just flicking through the notes, reading, getting themselves back up to speed, whilst the patient sat there in silence. And for me, that was sort of saying to the patient, I can't really remember you. I'm not sure where we were at. Just sit there for a moment while I work it out. And then a bit flustered at the end, having read the notes. So it was your knee, wasn't it? So the patient feels like, you know, everything that they talked through last time has been forgotten, that this person isn't really up to speed, and it's breaking down that rapport right from the start. So I like to go into a session already with a reasonable idea of what I might think would be useful in that session, obviously open to what they want to discuss, but I'm not going to be flicking through their notes. Quite the opposite. I'd often want to say, okay, well, last time we talked about this and this. What would you like to get out of today? We keep it open. Little hints that you show them that you remember them as a person are good as part of that. So it might be something like we had someone the other day that was decorating their house. So the next time they came in, I was like, oh, you were right in the middle of decorating last time. How are you getting on with that? So it's just those little things that show, I remember you actually. You're not just another person on my list. You're someone I know. And all of those things, they might feel small, but I do think they're really quite important to build that rapport.
Oh, 100, like, there's a couple of great things in there as well. I'm all over that stuff. I like the nitty gritties, because look, people love talking about themselves, and they love feeling important. I don't think I think it's a fairly human quality. It's not arrogance or vainness. It's just people like that, and I always ask questions about their kind of families and little quirky things. Like I had a guy in the other day as well. He I don't know how I remembered, but I knew he was doing houses up, and he was doing his sisters, and he was living his sisters. And I remembered all this from like a year and a half ago, and he was like, "Oh, how did you remember that?" And I went, I don't know, but these things stick in your head. And we kind of had a laugh about it. But again, that's bound to have some sort of, that as Robert Cialdini talks about similarity principle from his book Influence, that, you're similar, we're similar, there's connection built, isn't there, and I'm probably sick of saying this on this podcast, but the thing that you said there, which I bring you in a second, but that prep, isn't it? Thomas Deckers was on here saying the same thing. Just I often would say it, and I don't know if you do this as well, but like, I'll have the scenarios of what's possibly going to come in the door. Like, they're better and they're delighted, which is, we're all hoping for that one. And then you'll have some progressions for that, or where you might go. But then also, what happens if that doesn't happen? Where are we going? Am I sure of the diagnosis? Am I sure that there's a plan here? And then the other one is like, it all goes tits up and it's wrong and it was really bad, a bad reaction. Well, where am I going to go then? So I just even having that, as you said, because you'll be able to kind of be flexible within the session, rather than being like, oh God, right, I didn't think about it not being good. Do you know what I mean?
Absolutely. I think that's a great way to do it, to have an idea of what might be good to do when things are going well, but also something to come back to when things aren't going well. And I think sometimes it's just opening up the people to what you're thinking. So quite often I might say, well, from what you've told me, and might reflect back one or two bits so that they can see that I've listened, what I'm thinking is this, and then explain a little bit. And what would make sense is if we were to try this, this, and this. So we're letting them into our thinking, and then maybe saying, does that sort of chime in with your experience? Is there anything else you think might be useful for us to chat about around that? So he's kind of keeping that open conversation going backwards and forwards. And honesty is a key part of it. I think, when Joe was on your show, Joe Gibson was talking about the fact that we are human. And I think that's really important. We need to be human as therapists, to be approachable, to build that rapport. So I might say to someone, if I don't feel we quite have really a good idea what's going on, I might say, I don't feel we've quite got to the bottom of this yet. So, I'd like to look at this, and this, if that's okay with you. I'd also like to discuss these areas because I don't feel we quite got the whole story yet. Is that okay? And I think that's often what people want. They want to know that you're invested in them. I really want them to get better. I'm really invested in that. And so let's have a conversation around how we can achieve that together.
Yeah, like I think I'm trying to put myself in somebody who isn't biasedly really interested in all this stuff, and just sitting there going, right, well, what Tom's just said there sounds all really easy. When you said that, I'm like going, yeah, that sounds easy. And if I wasn't interested, I'd still think, oh yeah, I think I do that. But I was speaking to Ben on this as well, Ben Cormack, and he's like, yeah, but you don't know how shit you are when you realize, when you start looking into communication, and actually maybe you aren't saying that, and it isn't easy to be honest. And I think it's a great word, because like, you're mapping out to people like a journey that you should understand. So then therefore it should be understandable for them. And then we're both collaborating to get to that end, wherever that journey is, Yes. So you map out the journey. We both agree. So I think you said that really nicely, but that I think there's bravery, isn't there, with the honesty, and that probably comes with experience, and it can, but I don't think it's just experience. I think it's putting yourself in that skill where you kind of think, right, yeah, I don't feel right, and they don't feel right, so it's okay to be doing that. That takes bravery. I don't know if how you develop that in somebody or how you encourage it, but it's an absolutely, when you started talking about honesty, I was like going, I think if I was to think what skill I developed the most or felt most comfortable with, is that in the last few years. And I don't know what you find yourself around that,
Yeah, definitely. I think it's probably one of the things I enjoy the most is actually that kind of communication, learning about the other person. But I'll be honest as well, there's some things I struggle with. I think all of us, if we're honest, there's certain things we struggle with. What I find the most challenging is those patients that have an expectation of massage. And I'm sure we've all encountered them that are coming in and you've barely got into the subjective and they're starting to strip off and lie on the couch because they're not actually really interested in the conversation. We had a patient a while back who actually asked, how long are the sessions going to be spent doing massage? Because I don't want to spend the whole time talking. So those are the patients actually I find hard because they're not necessarily invested in having that conversation. So, those are patients I'll struggle with, being totally honest, trying to find a way of seeing if we can make them open to have the conversation to even start with. So, yeah, I certainly don't want to be sort of sitting here trying to pretend that I have all the answers. Certainly don't. I think all of us are learning and trying to find the best way and making mistakes sometimes too along the way as we learn.
Yeah, it's funny you said that, right? Because I did my course in Ireland last week, and I had some great questions on the course. It's probably because they were Irish, Tom, to be honest. But no, seriously, it hadn't been. I don't get it very often, which has kind of surprised me in some ways. But it doesn't surprise me. So the question was from somebody exactly what you said. They went, well, I hear what you're saying, Andrew, about all this. And so obviously it's an exercise course, but he went, I hear everything you're saying, that's great. He said, but people come with this expectation of hands-on therapy. And I was like going, he says, what do you do with them? Just like you said. And I was like going, I couldn't think of it. I just went, well, I don't get that from my patients. But then I'm like going, comes back to communication then. So if you come on my website, I don't mention anything about that. That's not what. So I suppose if you read around why you would come to see me, I don't mention any of that. So I guess I don't have to deal with that very often. So that's it. That's one thing. So I suppose if you are somebody who does that type of treatment, then again, you're going to struggle because people say, all right, that's on your list of stuff you do. So I'm going to go to them. And then that's the expectation. So yeah, I don't think I gave him a very good answer in the end because I just kind of said, yeah, I don't struggle with it because people come differently. So that's an interesting one. Yeah, I don't know. I'm just saying it out loud. It's just a funny one, right?
So in a way, you found a solution to it by making sure that your information isn't centered around that kind of treatment, and so it probably makes it less likely someone's coming to you for that, which is a really good potential solution for it. I think for me, there's a couple of approaches I tend to go with is. If I really feel that that's all that they want is just massage, and occasionally genuinely is, then I will say to them that, I say, well, I may not be the best person for you to see actually, because my management approach doesn't tend to center around just that. So if you really do just want soft tissue work, that's no problem at all.
Yeah.
But I can recommend someone who is going to be a much better fit for you, and then put that option back in their hands, and tell them what we might offer instead and why. The reason why we're not going to just do massage every week is because I want to help you get better and get better long-term results. And in many of them, they may have already tried massage and it hasn't really changed things. So there's often a little bit of openness to actually trying something different. So if there is that, I'm someone who's prepared to do a little bit of give and take. So sometimes we'll say, okay, well, we'll do some soft tissue work and we'll use that time to discuss the things that we might want to discuss subjectively. So it isn't just, right, you're coming in for a rub. That's where we're going to maybe talk to them about load management and sleep and education and strength and conditioning and try to use that little bit of give and take to build some rapport. But I'm not saying that's the right way to do it, but that has worked, with patients for me in the past. Yeah,
I think I said something similar to him. I said and I think that's great, and I hope he listens, because it was more, he was definitely desperate to kind of move away from that idea, but then I kind of said you kind of have to take the leap in the communication around that. So I think that's what I did. And then I have people who are great at it and love it, so I'm like, oh, if you're into that, there you go see those guys, and if you're interested in. But that's a good little segue, because people talk about that kind of time when you are doing any kind of manual with people. It is a great time to have that connection again, and I suppose there could be that stage of weaning off that. It's like, yeah, well, it hasn't worked before, exactly like you said, and we could spend a lot more time with the training side of things, which would be maybe worth your while, and then actually, and I suppose again it depends on the cost, but if you're paying for your expertise in injury, you know, it's going to be a lot. It generally is going to be more expensive than if you go and get some hands-on treatment from somebody who could spend a whole hour doing it for you. Do you know what I mean? So there's probably a little bit of that discussion as well, I guess.
Yes, yeah, and I must admit, it's not a common problem I have these days. It's occasionally we get it with runners, but yeah, I think hopefully a bit like you, where we've set up our communication helps people come in with a slightly different expectation.
Sound. Well, I'm going to have a little look at some of the other questions because that kind of answered a few things in there, which is kind of, again, quite useful. So let's see, what else have I put on here? So your education courses emphasize both evidence and practicality, which is really important in my opinion, especially for a good course. Over the years, you've shifted from in-person to global online delivery. How has your teaching and communication style changed with that shift? And what have you learned from that?
Yeah, there's been lots of changes with that. So I think when I look back on my old slides, they were very word heavy and, you know, a bit overwhelming for people. And I think one of the things I've done both online and in person with the course is more of what I call show and tell, you know, a bit like they talk about in the US. So I'm going to show the person visually wherever I can and then tell them about it, so that there is a mixture of those two things. So you've got some visual information, information like you see on my infographics, and then you've got some text alongside it. So as much as possible, particularly with the online stuff, making those lectures dynamic and interesting and engaging and visual. And you know, if you're doing part of that education via social media, trying to be on board with that as well, and that's a whole other challenge, because it needs to be short and it needs to have a hook and it needs to be quite different from certainly how lectures used to look when I was at uni many moons ago. So yeah, I think I've changed quite a lot of things with it. I think good education is often a conversation as well. So when I'm doing the in-person courses, I like to invite questions and discussion points, and we've integrated those within the online course. So we have live Q&A sessions and things as well. So you want to have that back and forth, really. I think that's often how good learning occurs.
I agree. Yeah, I think so. I think, you know, and like as I said, my recent one there was some great questions asked. I think, like, you know, there was like 10 or 15, like, those kind of really awkward ones around it. And it makes the course, doesn't it? And it also triggers you into opening it up to, you've got 30 people in here with all different experiences. So you're like I always say to people, if you've got questions, it's great, because if I don't have the answers, there's 29 other people here who give us a suggestion, and it might spiral into something else, and then it'll be on a slide the next course I do because I'll have robbed it from you, like, you know. So it's the back to the honesty around, like we do with the patients we were talking about earlier. You know, you have that honesty of, look, I'm not quite sure where we're going, we may need to go down this route to get an answer. It's the same what I think I've learned from my teaching recently as well, is that kind of honesty around, yeah, like like you said it, we don't know all the answers, being comfortable with that, and actually kind of learning off everyone in the room to kind of go, and actually that is something that we may not be able to answer, or it might be different for you over there. But at least we're asking those questions, those awkward communication questions, I think, anyway, which I don't think we may have done in the past, you know? No,
that's it. And they're important questions to answer, and you know, they are linked with outcomes. I mean, a big area that I obviously do research in is tendinopathy. It's a huge thing with runners, and there's a really interesting study recently from Aidan Rich comparing shockwave treatment with progressive physiotherapy for proximal hamstring tendinopathy. Really good study, but actually another part of what they did with that data is they asked the participants what they perceived was beneficial about their treatment. And they actually perceived the rapport with the physiotherapist and the education as being really important. And then they had separate sort of things they thought, like the physiotherapy was great for restoring strength, for example. The shockwave was good because it was quite convenient and didn't actually have much of a burden of treatment, whereas the physio required a lot more from them. But even the patients, they're acknowledging that education and rapport is really important. So we do need to focus on, like, how can we work on that? And I think it's a harder thing to study, isn't it? It's definitely a sort of softer skill that requires quite a lot of judgment.
Yeah, and I think that's the problem with it, isn't it? And everyone doesn't want to be, I always I've always kind of say, like, when you're given feedback on your communication style, it's much harder than if you just didn't do a test, or you didn't ask a question about a red flag or a tissue pathology, or you missed that thing and you just didn't get the mechanism of injury which told you everything. There's those things, but your actual, that rapport stuff, there's no it's so difficult to research as well, because I don't know, ever see that I think it's O'Sullivan's stuff, Peter Sullivan's reassurance research they did. I think they transcribed 5 people giving reassurance to patients, and they actually have the transcripts as examples in the paper. I can't remember what year it was. It wasn't long ago, and it was interesting what the therapist kept reassuring the patient of was not what the patient want reassurance about. So it's like the quality of the reassurance. So you and when you read through the text, like one of the examples, and I'm paraphrasing here, was the patient mentioned the MRI or something, but then the physio just kept reassuring them about the MRI being okay, but the patient kept going, I'm not worried about my MRI. I'm worried about this thing. And then the physio would say something and then go, but your MRI is fine. Your MRI is fine. And it just kept happening. And I think at the time, if you read it, you're kind of thinking, what was that physio thinking? But when you're verbally doing it and having to take information, and you're fixated in trying to think what you think the person wants, it's so difficult. Do you know what I mean? Even when people are being recorded, they're still doing this. And I think that the idea of how do we measure quality in this, it's very difficult. And you mentioned a paper there about like what patients think, what they want. It's usually rapport. There's a great study, they did it in surgeons and physios around ACL reconstruction. And those who got on better, they used a scale, I can't remember the name of it now, but there's a validated scale for surgeons, not for physios, but they used the scale for both. And what it found is that those who had better therapist and surgeon relationships, like they scored high on this, they went back to pre-injury return to sport scores. So that was the only difference in the rehab, was the relationship measured by how well you got on with the surgeon and the therapist, which I think is fascinating. That's that's getting back to pre-injury sport levels.
Wow, it shows how important it is. And I think reassurance is another one that's tricky to get right, because reassurance without empathy can sometimes be a bit invalidating. So what I mean by that is if a patient that comes in and let's say they've got severe low back pain and they're really concerned about it, and you think, well, I'm going to reassure them by saying there's nothing really wrong here, they might think, well, you haven't really understood how big a problem this is for me. This has been a real nightmare. I can't work. I'm in agony. I can barely move. And you're just telling me there's nothing wrong. So we think we're reassuring, but actually we're invalidating their experience sometimes. So I think it's a careful balance there of maybe saying, look, I can see you've had a really tough time with this, and actually it's had a big impact on you and your life, and reflect back some of the things they're saying. I've gone through all the tests we need to do. I'm happy to say that there isn't anything serious here, but I recognise it can be very painful. And then we go on to explain that, yes, this can be very, very painful, and we go into a little bit more detail. But I think it involves a little bit of that, validating their experience alongside the reassurance.
Yeah, absolutely. And I if I'm going to make an observation, I could be incorrect. I think that's when I get second opinion work, or a physio sits in with me to say, that's the things that they'll always go, oh shit, I didn't ask enough about that, or you got that information from them about this history. Where did that come from? And it was because of those little questions. And again, it's really difficult. You can't prepare for that, because it happens organically within the session, doesn't it? Which I think comes from the skill of empathy, which is to try and nearly be completely, it's like mindfulness, isn't it? It's like you're engulfed in the story and you're allowing your own emotion to kind of go, I'm in their person's world for a while. And like some people struggle with that. And I think, there's empathic distress and all the other stuff that comes with, there's the other moral fatigue that you've got, and all the things of like pushing yourself. And we know that's a real thing as well. But I think it would be a skill missed if you don't kind of try and, get in the moment, of that emotion, and then recognize it and really kind of think, fucking hell, that's bad, And I think when you said there about the serious and severe, it's like, I'll always go to a patient, I don't know what your technique is, but I would say, I was like going, so I've asked you some questions and we've got some information. The good news is it's not serious, But the bad news is it can be really severe. And then I'll usually say, like, yeah, actually, weirdly, you can have really serious and not severe. And then I'll use the example of something like a cancer that you can't, or something that cancers can be quiet. And that's the reasons why they kill people, because, they can be quiet. Don't necessarily jump down the cancer route like that. But that idea that they kind of realize that not everything that's really severe is very serious. And I think there's a lot of people are just like, oh shit, right, okay. Do you know what I mean? Like, they are reassured by that. But yet, again, spending that 2 minutes with that, rather than jumping to more questions that you want to get answered, we just don't get taught that kind of, that feeling and to trust that feeling when you're in. And I don't know what physio educators are like nowadays, because we're so desperate to not miss things. I'm always a bit like, I think you're missing things because you're missing this. Do you know what I mean?
Yeah, absolutely. I think sometimes having little phrases and analogies and things like you've used there, say, I think that's a really nice sort of saying that it can be very severe, but that doesn't always mean it's serious. I quite like that we're using cramp as an example, because cramp is bloody painful. It really, really hurts. And yet we know it's not serious because it goes away so quickly, but it's something most people will have experienced. And we'll say, actually, do you know what? That makes a bit sense. Yeah, that really, really does hurt, but it's not anything serious. So I think those little kind of comparisons, analogies, even stories sometimes, if there's something that the patient can kind of relate to, can be, really quite useful, I think.
And that's, so you meant, like, I don't know when you read about stuff, but, stories keep, I'm kind of fascinated with journalists and how they keep doing their job, because just coming up with stories and stuff, and they are. I never thought of journalists weirdly as storytellers. I'm not a reader. I have to listen to things. I've never been a great reader. I just can't concentrate. Really struggled with it all my life. And people were like, "Oh, you just need to do more reading." And I was like, "Going, I fucking tried. Like, it's not my thing." And then audio stuff came out, and I was like, unbelievable transformations, But that idea that journalists told stories, and then I'm like going, of course they do. And then I'm like going, and that's why people get really taken away by this. And then I kind of went, oh, that's interesting. Everything is, story based, and you listen to how things are passed on before records. The only reason we know about stuff is through stories. And then realizing that my culture from Ireland is built on that, and mythology and all that kind of stuff. And then I'm like, oh, fucking hell. I probably in that, you're in it, you don't realize what's happening. And people say, oh, Irish people are like this. And I'm like going, I suppose that's the way we are. That's it. You're in it, so you don't really see what we do. It's like when you ask Irish people for directions, they tell you a story rather than where the situation. Do you know what I mean? So it's interesting you say that. And then, like, what would you say to therapists or, like, around that and building their confidence around being okay with that kind of side of things? Don't know if that's a question, but,
Yeah, I think it's worth just taking some time out and reflecting or chatting to a colleague just around a few sort of stories and experiences that you think might be useful. It might be, previous patient stories sometimes. I mean, we always have to be mindful of confidentiality with those, so you have to pick those carefully. But, stuff that you think actually this might reflect quite nicely on this person's experience, stuff that's actually happened in like everyday life, stuff that's been out there in the media sometimes. So for example, one of the things we'll often encourage runners to do is cross training, maybe to replace some of their running whilst they're preparing for an event. And some years ago, James Cracknell was doing the Marathon des Sables, for example, and he injured his hip. And he was told not to do any running. And I think he didn't run at all for something like 6 weeks prior to the Marathon des Sables. He just cross-trained on a bike. But I believe he was still the highest finishing British male that year. So, that kind of thing is quite a nice way of sort of showing the potential value of cross-training. Here's someone who's not run for 6 weeks prior to a multi-day marathon event and has still done really well. So those little stories, little patient success stories. We had a gentleman many years ago now that who had persistent low back pain and had that classic story of don't flex, don't bend, don't move at all. And he was really open to change. He was an incredible guy. And he said the thing he wanted to do was cycle. but we got him on the exercise bike. He could manage about a minute before he had this really quite severe back pain, started to get some leg symptoms with it. So we agreed we'd start just under a minute, and we just build up at a pace that felt right for him. Eventually did the London to Brighton bike ride. So he was someone who went from a minute to, I think it's about 80 miles. And those kind of stories are quite useful. I'm sure most therapists listening in, I bet you'll have maybe one or two little examples in the past of things like that where it has gone well, where you've done that kind of graded return to activity and someone has got back. So those little success stories, they can be a useful part of your, your toolbox, I guess, in a way to share with patients.
Yeah, I think you just triggered something in my head there about, like, I guess listening to this, the scary things when you're like a younger physio or less experienced, you don't have that to rely on, you know what I mean? But you also, because we come from a fairly strict, like you mentioned confidentiality, like it's, straight away it's like, right, okay, be careful GDPR, confidentiality, yeah. And I think that's obviously extremely important, but I think at the same time the way we're taught it is so kind of like, it takes away the human nature of it. And I think that's maybe where we need to get some lessons on it. I suppose that's why I'm such an advocate for coaching courses or communication courses, because yes, you need to be clear on where you are from a legal perspective, but at the same time, once you know that, there's so much other stuff you can play with. Like you said, like sometimes in the moment, this story is going to absolutely unlock somebody. You know what I mean? Yes. And I think there's no better area than replacement surgery, particularly in the last, 10 years. Mehmet Jen's really good at stuff like this, and there's loads of people out there like real advocates for doing quite significant stuff when you've had a hip replacement or a knee replacement, and this old thought of that's it, you're screwed, you know what I mean? And I think those stories are very powerful for people trying to make a difficult decision maybe in their early 50s around replacement surgery, and just kind of going, well, what can I get back to? Like, is this me done and now I'm an old person like that? Because that's where people are, and I just don't think I would have gone there when I was in my 20s as a physio. I kind of would have, that wouldn't have just been a different stratosphere, So I think it's just being I suppose my thing is always just being interested in the idea that collect as many of these things as possible and have those conversations, because they will help you as a therapist, even though they mightn't feel like it at the time. Do you know what I mean?
Absolutely. And I think, my understanding with the confidentiality is you just have to be careful not to share personally sensitive data. So we're never mentioning, anything around name or personal information. We keep the stories as vague as we can so that they deliver a message, but they wouldn't be in any way revealing sensitive information about someone. I think that would be my understanding of it. But you do get some nice examples, as I said, out there in the media. There was an incredible athlete who now has the nickname the Iron Nun, who completed an Ironman in her 80s. I think she was 87.
Oh, wow.
So I quite like having a little story or two for each of the different scenarios we sometimes get. So that was really useful for a patient who was only in her 60s and had been told she was too mature for running, which I don't agree with at all. I think you run for as long as you want to run. So that was a good story to say, well, actually, have you heard of this, Sister Madonna Buddha that was doing Ironman competitions in her 80s? And so it's those little things. If you pick up a little story like that, you think, do you know what, that might be quite useful for those patients. Or you're talking about with Mehmet Jem, people that have gone back. There's people that have done ultra marathons after hip replacements. Those little examples can come in useful when you're in those situations with patients.
Yeah, you don't need loads. Like you said, it's like a library. It's like a library of stuff. And I can say about exercise, to be honest, people get really surprised when they come on the course. I'm sure you're the same. Like, I don't have millions of exercises. Like, it's very much the same ones with different intensities and targets. Like, I could give a squat for about 10 different targets. One and only one of them is strength. The rest of them could be anything from confidence to reassurance to, you name it. Like, it's just, but it's the same thing. It's how you dress it up. So having just a few stories around things, again, especially if you're maybe less experienced, I think would be a really good one. But it also brought me into, you said there, which is great. Like, I don't know what you think about what I've learned, again, I suppose, I don't know, in the last few years anyway, certainly in the last 10 years, is around the choice. which I think is a great way. You know, I used to be really scared of, you know, saying to patients like to return to something, like because I think, oh, what happens if something happens to them, and then that, you know, it's nearly like I'm like, oh, I better be safe than sorry kind of thing, and I'm like going, hang on, this has nothing to do with me. It's nothing to do with me at all, actually. And all I can just, you know, there's no absolutes in anything that we're doing, so we're kind of going, right, well, look, it's all about risk, it's all about probability. These are the kind of general rules that will probably keep you further down this way or whatever. But ultimately, if people say to me, there was a guy, actually, yeah, it reminds me, he's a runner. He's going to do, he's tried to do the Arc of Attrition down in Cornwall. You know that one?
Ooh,
the Ultra?
Yeah, that's tough.
Yeah. So he was training for that. Like, it's in January as well. Like, it's just awful. And so we get loads of people trying to do that. And he medial tibial stress syndrome. So it binned him out for that. And he's a really dedicated guy, and he's trained loads. So he was raging about that. And then like you well know with runners, you know, I'm getting in and he's coming in, he's going around better than that now. And I said, okay, cool. So we're going to go through your progressive loading now. And he's like going, yeah. And I said, when's your race? And he went, oh, I booked this 100K in May, you know. And I was like, and I went, where is it? And he said, in the Peaks, and it's up at Snowdonia, I think, or something mental, like. And I went, okay, fine. And he said, oh, well, I'm going there with my girlfriend, so we're there for 2 weeks, and we're going to do this run. Anyway, so we did this back and forth. So we just had this kind of conversation, and I won't go into too much detail, but the back and forth was eventually this choice around, like, what's the risk? What are you going to feel like afterwards if you get injured, and then you're going to be out for it, and how that will affect you mentally, right? We've got to think about that. What's the consequences? What's the consequences of you going on this? What happens if you DNF or whatever? Is that going to be a hard one because your brain will change when you're out there? And then the back and forth on the WhatsApps was, he just kept saying, what about the 50K? And then I said, then I threw out a few other things. It says, well, you're going to Vegas, and I said, and you're putting it all on black, and you might win, and that's great, but you know, you may lose. So we're here. And then he sends me back another gif of you know, the Hangover or something like that, and he's like, I'm all in. But basically the story was just like, he kind of just went, look, I'm informed and I'm making the choice. And I just went, that's cool, and let's do our best between now and then to get you in the best shape. And whatever you decide, you decide. I think that's been one of the best things I've realised, and didn't realise that for a long time for some reason.
I think that you've hit the nail on the head with that one. It's so important, because as therapists, you can carry a lot of weight if you feel you're responsible for the patient's decisions. Whereas if you recognise that actually this is two people working together, and what you're actually aiming to do is, just like you've done there, is help them make an informed choice. You're not there to tell them what to do. That's not our role, but we help them make an informed choice, and that involves discussing the risk and reward. And that's that balance. We talk about it on my courses, like that balance of risk versus reward. What could be the negative downsides of attempting this? What would be the upsides? What would be the good things that you want to get out of it? And then I think, you know, good therapists will look for ways to manage or reduce the risk and really enhance the reward they can get from different interventions. So some things have a very low risk profile, like good nutrition, good sleep, planning recovery. There's not really a great deal of risk in those, but there's high reward. So we would look at saying, well, let's get those things in place. Let's try and make sure you're sleeping well, you're eating well, you're recovering well. Cross training, another thing that generally has a relatively low risk, high reward profile. So we can make them aware of the risks and the reward, and then we can help them manage those when they make the decision, I think.
Yeah, and just if anyone is listening who's a therapist, then like, you've got absolutely, I've seen that and something you've put out before, that some diagrams, and definitely. So if you want to check, because you've got are you running physio.com? Is that where you're... running-physio.com. Yeah. And is that where your blogs are on there and stuff like that?
Yeah, all the blogs are on there. Yeah. So I'm a big believer in recovery and sleep and things like that. And, you know, especially you've got someone like that, you're talking about doing a 50K or 100K, you know, that's got to be something that we chat about, I think. Yeah,
I know. So definitely check that out, because they're, you know, again, they're invaluable resources. I'm going to go on. What's one coaching question you wish every therapist asked their runner early in treatment, and one question you hope they never ask?
Okay, yeah, that's a difficult one.
I was going to say it's a shitty one, but
no, it's a good one. It's a good one. I think one of the things I would try and make sure that we do ask people is what is it that you're hoping to get from from our time working together? What are you really hoping to get from this? Because it's so important to know that early on. What do they want out of that time? Because not everyone is the same, and sometimes actually people want, say, a diagnosis, or they want to be told it's not something that they're really worried about it being. They might think they've got a stress fracture and they really want to be reassured that they don't. Some maybe do want some hands-on, some want some training advice. But if we know what they want, if we ask that question, then we're in a much better position to help. And one thing I would say is never to ask is, why haven't you done what I told you to do?
That's a great answer.
Because that is like, I'm the boss. I'm telling you what to do. Why haven't you done what you're told? That's not coaching. That's not two people on a level, No. So yeah.
No, that's a great answer. Yeah, no, it's great. I have like one of the things I ask for to know what you do is when they come back and you may have set them a program of exercise. So my first question is like, how did you get on with the exercises? Were any of them like, would you rather, I always say, would you rather drink cat sick than do any of these exercises? Like, is there, or you insert whatever horrible thing you would not like to do, to lighten up the humor. Like, would you rather lick sandpaper or do the side plank for, and it's interesting, you get the answers back because you give them permission to say, look, I need to know if you don't like them, because there's no one exercise that's superior to the other. Like there's just certain things that, yes, could be useful. However, if it's going to like ruin your day or ruin the kind of program, then it's got to go. And even when you say it's got to go, it's like, it's fine because I'll find something else. There's no issue here. So you get there's two answers usually, which is like, oh yeah, great, brilliant, I hate that one, that's the one I really know it, brilliant. So you've kind of got that little rapport of you understand the empathy side of things. But then at the same time, there's other people who are a little bit like, I don't like it, but the fact that you said it to me and now being really sound about it, I'm going to fucking do it anyway. It's kind of, it's like a weird reverse psychology that they're kind of, no, I'll stick with it. I think you said it was important, so I'm going to do it. So one way or the other, again, it comes down to choice, isn't it? Which, like, have you actually, and again, there's no right answer to this, but like, have you done any kind of formal communication or coaching stuff, or do you just read around that stuff, or what have you done to
Not recently. I mean, we something, when I was learning about persistent pain, we had sort of like in-house training sessions on communication styles and stuff like that. So I've done it as particularly when I was in the NHS, we did a lot of kind of in-house training around stuff like that. I've done some sort of supervision courses, things like that, but not anything more established than that. It's a lot more kind of reading around the topic, a lot more just sort of working with people, seeing what works. Really, rather than formal training, I would say.
That's good. I think that's good also for people, because a lot of people will ask that question. I don't know if you get that as well. How do you get good at it? And and it's a little bit like, you can do an awful lot of reading around it. I think, again, going back to the very first episode with Ben Cormack, he just says, I think it's just really. He just says he's lucky, and I agree with him as well. It's like, I'm just interested in people. Interested in that the psychology of it. I'm really, like, I'll often say to on the course as well, I don't know, I like certain subgroups of people, the patients that you just click with and that have it, it's going to go well and stuff like that. But it's quite interesting. I have quite a good laugh with, like, women in my age group who've got young kids, is like similar to me, and just like basically be like my wife, who's like, they're just super busy trying to do everything. It's like, it's a fucking shit show. Like, they're so busy trying to do everything, and I know what it's like because I'm, my wife's the same, and I have unbelievable kind of patience and empathy and like listen and do it all, plan it all out really, and really feel it, but I'm not emotionally attached to them. And I'm really shit at doing that when I go home. I'm just like, that's you think you're good at communication, and I'm like going, no, because it'll change depending on how your emotion is with the person in front of you. So it's quite interesting, isn't it? Like, just being aware of your own emotions, aware of how it'll change and that you probably will mess up and stuff like that. I think that's one of the most important things that I've realised.
And reflecting a bit on, like, because we've all had encounters where we've been a patient. In reflecting on the ones, think about, if you're maybe a new therapist and you're struggling with this, like, think about an encounter you've had with a health professional that was good. What made it good? What made it good? And have a reflect on that, because that's often a good clue as to, like, what what other patients will find beneficial. And likewise, if you've had a negative experience with a health professional, what about it wasn't good? And quite often it's when we're dismissed and we're not listened to, or the person's distracted, they're not really paying attention. I had a classic one. I went to GP with chest pain. And all fine, but it's one of those things I wanted to get checked out because chest pain you don't mess about with. So I went to the GP about it, and he was there looking at his computer, and he looked back at me and he said, "How do you spell anxious?" He literally asked me, and I was like, "Are you taking a mick? You might as well just be telling me I'm making it up." And I was just like,
are you joking me?
You're not. No, that's literally what he said to me. And I was just like, wow, you couldn't take this less seriously if you tried. Like, I didn't say that to him, but I just thought, wow, that's such poor communication. He hadn't thought for a minute that would be a bad thing to say. So, I think reflecting on those good encounters, those bad encounters, being human, be as human as you can be, like, what values do you have that you want to show to the patient that can be part of that? I've always someone who likes to be, like, warm and humorous and easygoing. I have a little stash of emergency chocolate in clinic, for example, because we'll have people come in, you can tell they're rushed, they're flustered, and they're saying, I can't even have time for lunch. Do you know what you need? Emergency chocolate. Open up the emergency chocolate drawer.
Nice.
That gets people on side really quickly. Just little things like that. That's just like, let's kind of meet on that kind of level, and bring the values in that you think are important.
That's great. That's quality. That's like these are the things, like, that's it. That's the only thing I need to take from this podcast is chocolate, emergency chocolate.
Emergency chocolate. Yeah.
Yeah. But it doesn't take much. I think that's what we were trying to explain empathy earlier on, or I've tried to do it several times with other people, and it's those things. That's like at the right time. It's like having the tissues is one kind of classic thing. Just having that and understanding that this is a moment that we need to. But and I think if you're listening, or if you're trying to be a therapist, the beauty about all this stuff is you can just put your own little tinge on it. You can have it, and you can be aware of it. Jo said as well, like, I remember her classic story on her course. She said, she started off, Jo said, and she was going into it and she was just making a hash, she said. And then she just went to the patient, I'm really sorry. I think she'd had some bad news or something, or I think her dad might have been unwell or something. And, her head was all over the place, but she just ranted and raved. And then she went, oh, I'm really sorry. I'm going to have to stop here. I've made a hash of that. And then the woman just went, don't worry, you can start again. Do you know what I mean? And then she did, and that was grand. So even when you mess up or you're not really doing very well with it, you can always just go, look, this is I've got it wrong. I've come across, and I've done that with patients. You just not maybe in great form. They come in, they're a little bit rude. It can definitely affect you. You know what I mean? You're just a bit sharper. Your questions are a bit like, you know what? I'm not in the mood for this now. And I've caught myself I've caught myself. And one patient said to me, I went out and I opened the door, and he was in a wheelchair, big huge guy, and he said, are you okay? And that was the first thing he said to me. I just opened the door, and he went, are you okay? And I went, yeah, I am. I said, no, I'm not actually. Sorry, I'm not. Yeah, no, I'm not actually. I'm not feeling too well. And he went, I said, all right. His wife wheeled him in. We sat in there in the clinic, and he came down, and I went, I'm really sorry. I said, I wasn't right coming out there. And it was all over my face. And that was the first thing he said to me. Now, this guy had a condition that was just, there was no treatment options for him, right? And he just wanted to know that there was nothing. And I think probably when I read the referral, looking back now, I've gone, why have they set this patient to me? This is really a waste of time and his time, and I'm now going to have to, deliver bad news, really. And I think that probably came across, and he picked it up, and then I kind of went, anyway, it turns, it's a long story, but he comes in, we chat, and I give him that information, and he's like, he says, really thank you for that, because that just, now I know what I'm dealing with, that's fine. And then he said, whereabouts in Ireland are you from? And then we spent 25 minutes talking about it. He's travelled all over Ireland, sees this country and western singer from my home county that, I just knew his name. He went, oh yeah, I love him, met him and all this. We chatting away, and then it turned out to be I didn't do very much physioing or anything, but I had a really good chat with somebody and felt really good after that session. Do you know what I mean? And these sessions can happen. And he went off happy as Larry with his wife. We had a good laugh and everything. And I'm telling you the story, I suppose that I'm sure you've got a bunch of those kind of things where you think, what am I doing as a therapist? But sometimes it's just, I got caught in the moment, transferred it, and then 40 minutes later I'm having a laugh with some stranger who's got an unoperable knee, which is a bit weird.
But it's good though, because again, it's one of those ones you can reflect on, and you can see in a way, his response to you was how we need to be with patients sometimes.
Yeah.
I've had situations with patients where they've turned up late, and they've struggled to find somewhere to park, and they're stressed, and you can see it on them. They're flushed, they're stressed. Then they're not really ready to engage in an assessment. They need 5 minutes to gather to gather themselves. And sometimes you do that, and you look in the diary and you think, I've got a notes gap after this one. And you might sort of say, do you know what? I can tell you've had a bit of a stressful journey getting here. I know sometimes the traffic and the parking can be a nightmare. Would you like it if we just nudged the appointment back 15, 20 minutes or so, just to give you a few minutes? There's a coffee shop over the road if you want to. We've done that with patients sometimes, and they come back transformed because they've just had that chance to go, and you can say you're still going to get all the treatment time you need, but do you know what? I'll do some admin. I've got a notes gap after you. So I think, it's good to do that, to recognise, that guy was obviously pretty good. You recognise you weren't quite there. I think we've got to recognise when our patients aren't quite ready yet either.
Yeah, no, definitely. I think, and it's the skill that, and it's hard, we've got there's two emotional beings in one room with, one is extremely anxious that you may tell them really bad news, or that they may have to have surgery, or they may not be able to run, or for a period of time. There's a whole barrel of anxiety from their side, and then there's a whole barrel of, if you're a therapist, of, am I going to be able to solve this problem? Am I going to know what's going on? Is this going to be a hard one for me? I definitely still get that kind of, especially in patients who come and paying money, because that you have to at the end you have to take the money off them, and it's you really want to do a really good thorough job. So there's a pressure, to meet expectations and stuff like that. But it's definitely something that if people are listening, I think it is definitely a skill that I think people should work on as much as possible. So thanks for that, Tom. That's brilliant.
And that pressure doesn't disappear either. That's the thing.
No.
As you get more experienced, particularly if your name gets out there, you feel the pressure. The pressure remains because people's expectations are now higher. So I think it's sort of there throughout, and I think we all probably feel that a little bit. I've had patients, I'm sure you have, that have travelled a long way to me. And when that happens, you think, gosh, you've flown over from somewhere else to see me. Crikey, this better be awesome. Otherwise, it's going to feel like it's perhaps not been the best use of your time. So we can feel that pressure. And then, I think if we're always committed to try and get good solutions for them, and that's what's driving us, I think that can take away that pressure to some degree, because you're always going to try your best for that patient. You're always invested in their care, and I think that's important for people.
I think it's a good point there as well. That pressure to do a really thorough assessment, and sometimes with your time, you may only have an hour, and in that time you should really dive more into the conversation and the history. But as you said, the pressure of doing this kind of really fancy assessment and getting the kit out and measuring and all that kind of stuff, which is, again, has its place and very important. But sometimes you just have to be comfortable with actually that is hard. It's a pressure. There's definitely a pressure there, I think, and you feel it sometimes more than others. And I guess depends on how you work, but setting that up. We talked about the manual therapy earlier on. I suppose the messaging and when people are coming prepared for that appointment, that this may. I've often kind of gone half an hour in, gone right. I've stopped them and said, look, we need to carry on with this conversation, but it will mean that we will have to go into somewhere else next time, or we won't have time for that, which I think takes bravery. Again, we mentioned this earlier on, and again, there's no quick answer for that. But I think just being confident with what you're. I think it's the communication. You mentioned it earlier on as well. Just being kind of clear about what's the expectation here.
Absolutely. I mean, I've had quite a few situations where we've only done the subjective. And, that might be, saying to the patient, when you become aware that actually that's likely to happen, you might say something like, I can see that you've been through a lot here and you've got quite a complicated story. I'd really like to hear all of it. Do you mind if we just focus today on going through that together? What that will mean is we'll do the physical test next time, if that's okay with you. And I've never had a patient say no to that. Actually, quite often they'll prefer you to know their whole story. And also the thing of knowing what they're really wanting to get out of today, because we've got some snazzy kit and stuff, and there's a place for that. But I've never had a patient when you say, what do you really want to get out of today? Do you know what? I want to get on that snazzy kit. I want you to get me on the force plate, or I want you to get me on the handheld dynamometer. They're not asking for that. So we might feel pressured to do those high-end tests, but actually, if we know what they want and we deliver that, that's more important. Those tests can come later, I think. Yeah,
cool. It's going to finish on just a question. Apart from your family, I'm going to not allow you to take running either. It's too obvious. Something that maybe people might know, but what do you really enjoy doing for fun?
Oh, I'm a huge foodie. I absolutely love my food, which might be part of the reason why I have an emergency chocolate stash. Which I may occasionally nibble on. But yeah, I'm a massive food fan. I love all types of food. I'm a big fan of like bread, good cheese, good wine. Yeah, that's a good night in for me. Followed by usually some kind of lansoprazole or something afterwards.
just chop up a bit of lansoprazole afterwards to wash it down.
Yeah.
Well, I won't go into it, but you should check out my food analogy then on exercise prescription.
Oh yeah, I should. Yeah, I'll look into that one.
You need to look into that one, which is Italian food, and why most of your patients are Italian food. Which is, have you never heard that one from me?
No, come on, I need to know now.
Yeah. You see, sick people are sick. So the idea that so like what we've just been, kind of what we've been talking about, this pressure of how do we know how much exercise we're going to give to somebody, or how are we going to recognize the kind of person in front of us from an exercise point of view? Like someone sits down, they start telling us things like, how do I know it'll be 1, 5 exercises, etc. Right? So I've always been really interested in why we end up coming up with this, So I was kind of thinking, the thing I came up with was Italian food is, most patients are Italian, which is between 1 and 3 exercises maximum. And one of those could even be education. It doesn't even have to be exercise. It could be the education component. So when you've been to Italy, the quality of food, they only have pasta and a bit of sauce and cheese, and it's unbelievable. So it's high quality ingredients, done really well. And that's what sometimes people want to throw 5 or 6 things at somebody who is clearly telling you they do not exercise, do not enjoy it. And the research tells us they won't do it. So behavior change, all that stuff says you can't shove this down their throat. So most of our patients, when you look at the physical activity, percentages, don't do any exercise, right? And then we have Indian food, which is athletic people. So people who like, and that doesn't mean they have to be athletes. They just schedule time for training, can cope with, probably if they go to the gym, they're going to be doing 5 or 6 things. So the idea is that, have you got an Italian in front of you or an Indian food in front of you? Because once you recognize that, I'll be going, right, so I'll only need to do one thing here, which means I only need about 10 minutes or 1 minute or 5 minutes at the end of my treatment, or I'm already predicting that that's all I'm going to need. Or if somebody's coming into me going, I've got shoulder pain, I go to the gym, I might say, well, at the end, I can just change a few of the exercises in the gym, so I don't need to panic that I have to show them a whole bunch of stuff, which allows to buy me more time for my subjective at the beginning. So it's trying to reduce that anxiety from the therapist saying, oh, I've got to do all this stuff and I've got to give all these exercises, and not just give them a sheet at the end and say, try that. So that's the idea. And then the Mexican food is basically same but different. So you might come back and they do really well with squats, and instead of just changing the exercise, you give them a split squat. So it's slightly different, but it's the same pattern, for example. So I run through the fact that, are you going to just do Mexican food rather than to change something and risk making things worse because you've already found out that works. So that, and then American food is where they put pigs in the ground for a day and cook one ingredient very long. That's persistent pain. Because you will probably want to spend a lot of time finding the story. You're not going to turn around at the end to somebody who's seen 10 physios and 20 chiropractors or whatever and go, oh, I can't believe you're not doing a side plank. That's what's going to cure you. So the idea is that one ingredient is usually empathy, listening, and understanding somebody. So there you go. You're starving after that.
I love it. Yeah, when you do this on your course, I bet do you have to do it like after lunch so people aren't like starving and rushing off for food? That's
good. Actually, it's a good point. It is after lunch. It is actually after lunch. Yeah, it's good. Yeah, it is. I didn't know.
Well planned.
That's it. That was completely by accident, by the way. Listen, I won't take any more of your time, Tom. I really appreciate you coming on, and I hope to meet you in person one day.
Yeah, I'd really like that. And thanks for having me on. I've really enjoyed it. It's been great to chat to you about this kind of stuff. I feel that we could chat for hours about it, definitely. So thank you.
And yeah, people definitely check out your stuff because it's top class. Thanks again.
Thanks for listening to Teacup. If you liked it, tell all your friends. If you didn't, well, maybe you'll like the next one. Go to procareeducation.com or Procare Education on Instagram for more information on courses and the Bamboo Project. And remember, always be sound and not a dickhead.